my distinct pleasure to invite Dr. Shaf Keshavji on the podium. I had a longer introduction designed for him, but I'll tell you, he's the one person whom I got intimidated the most as I was trying to learn the field of lung transplant. And I still feel that his contribution to this field of not just lung transplant, but also ex vivo and in vivo systems, keeping the organs alive, assessing them, has been really, really remarkable and groundbreaking. I'm thankful for him to come from all the way from Barcelona and talk to us. I'm sure he's jet lagged, but I'm going to go and sit down there so I can enjoy this lecture well. I don't want to sit there with the light shining in my eyes. Dr. Shaf Keshavji.
Thank you very much for the honor of this lectureship, and I think, what would be very interesting to ASAIO is actually we, through lung transplantation, have learned how to support lungs beyond ECMO, to learn more about them and repair them, and then look at how we can use that knowledge moving back inside the body so that we don't have to take lungs out of you. I would like to disclose that I'm a founding partner of several companies that have spun out of the work that we've done: Perfusix Canada, Perfusix USA, which we sold to United Therapeutics, which is now called Lung Bioengineering, and XOR Labs that we sold to Triferox, which is now called Triferox Technologies, that makes ex vivo lung perfusion devices, and I serve as the Chief Medical Officer. We've also had a lot of industry support and partners, and I think it's really important for all of you to know that we could not have achieved what we did without the help of these people. So I was quite lucky to grow up in Toronto and train there, where the first successful single lung transplant in the world. The gentleman on the left, Tom Hall, is shown there. There's a YouTube video of that experience. It's called Lung Transplant Number 45, because that was the 45th attempt in the world and the first successful. In the middle there is the first double lung transplant in the world, and I happened to be scrubbed as a junior resident at her operation. Now, when you think about the miracle of transplantation, cold flush preservation really has been the cornerstone of success of organ transplantation. And although it's protective, cold hinders the possibility of active metabolic processes and repair, and the conceptual focus has been on slowing down death rather than facilitating recovery and regeneration of the organ. And really, we only find out how the organ works after we implant it. And in lungs particularly, but also in hearts and livers, this has made us as clinicians very conservative. In lungs, in the United States today, 80% of donor lungs are declined. And we thought, well, what if we could actually create a way to assess more organs outside the body, so that we could have a better chance to transplant more organs, and really moving the decision to the ex vivo platform. I think we could triple the number of lung transplants performed in the United States and around the world, and we've shown that. But more importantly, if you find something wrong with the lung, can you actually repair it? Can you actually pre-prepare that organ for the unusual journey of transplantation that you're going to put it through? And I think that if we could do this, we would transplant most of the organs and decline very few. And really, the concept is taking transplantation to the next level, using precision medicine to diagnose, resuscitate, repair, pre-prepare organs, or engineer super organs so that they're actually better than the way you found them before you implant them. Very early in my career, I got interested in gene therapy and interleukin-10. Interleukin-10 is a key regulatory cytokine in the transplant process. One, because it's very involved in the innate immune response of ischemia reperfusion injury, but also involved in the adapted immune response of rejection or the development of tolerance. So it's a key regulatory cytokine. And so what we first set out to do is say, could we use adenoviral vectors, the common cold vectors, to take the IL-10 gene into the lungs. These viruses are very good at getting in the lung, and really use the cell's machinery to produce IL-10, sort of make little IL-10 factories in the lung, if you will. So Stefan Fischer from Germany, who was working with us, showed that you could actually improve function of donor lungs if you treat them 12 hours prior to retrieval. And Saulo Martins from Brazil also did the same work in large animals, showing that you could improve the function of lungs after transplant if you modify them in the donor stage. So that was an important proof of concept that this was possible, that you could modify an organ prior to implanting it to have it do better after transplant. We realized that gene therapy took 6 to 9 hours, and it just wasn't practical to be flying all over the continent with our vial of gene therapy, put it in the lungs, and then have the heart and the liver and the kidney people say, just can you wait 6 or 9 hours while our gene therapy works? So we thought, look, if we could really revisit the concept of doing gene therapy outside the body, we could have time to do that. So we developed a system through components found in any hospital, a bed for the lung, if you will, a chamber, ventilated with a state-of-the-art protective lung ventilator like you have for your patients in the ICU, and perfused with a centrifugal pump, not a roller pump, that is gentle and conducive to not adding further vascular lung injury. And the pump is essentially swept backwards, and that it's swept with a gas that has very low O2 and some CO2, so that you can actually look at the lung's ability to work as a lung in removing CO2 and adding oxygen to the perfusate. And you can see that's the Toronto ex vivo lung perfusion system components, and on the bottom right is the device that we've brought to market to simplify this process. So really, this is work that Marcelo Sipal did when he was my fellow in the lab, and remarkably, and I'm sure this audience will understand that, this is lungs, pig lungs, normal lungs at 37 degrees, stable function for 12 hours outside the body, perfused. We also showed that it didn't matter in lungs whether it was cells or acellular perfusate, which became important in protecting the lung, but that we were measuring the same thing either way. And after transplanting, the lungs showed that we had excellent lung function in pigs after 12 hours of ex vivo lung perfusion at 37 degrees. So once we had this, we knew we'd hit a pretty important change in the field, and we designed the experiment to bring this clinically. 12 hours cold static preservation with PerfitX, which actually was my master's thesis. And then the second 12-hour preservation was 12 hours additionally of cold preservation, or 12 hours of normothermic EVLP, and then transplanted. So you can see that this experiment was designed for translation. With this, we can go pick up a lung anywhere in North America, bring it back to Toronto, put it on EVLP, and work on it to gene modify it. And we were looking for equivalence, but these lungs were far superior after having a 12-hour period of normothermic EVLP. We didn't understand it at the time, but we understand it now. So now we really have an opportunity to manipulate the preservation temperature as clinically required, according to your organ or clinical needs, and time to accurately assess, diagnose the organ and improve utilization, opportunity to treat, recover, and repair organs in a precision medicine way like we treat patients today, and an opportunity to reassess and confirm the results to know that that organ is now okay and safe to transplant, so improving the outcomes to make them more predictable and safe in transplantation. And for those of you that haven't seen this yet, this is what it looks like. These are human lungs on the Thorax system being evaluated at Toronto General Hospital. The lungs are breathing. They're perfused by an acellular perfusate, and you can evaluate the lungs to decide if they're transplantable or not, or treat them In this particular video, they're bronchoscoping the lungs to deliver the IL-10 gene therapy so that we can improve the function and immunological manipulation of the organ. But you can see how the ex vivo perfusion gives you that platform basically to work on the lungs and improve them over time. We brought this clinically in 2008. In the middle there is Marcelo Sippel, on the right is John Young, also a thoracic surgeon and my partner who did the IL-10 gene therapy as his PhD thesis. And we've done over 1,000 cases to date in Toronto. Importantly, we showed that you could perfuse lungs and evaluate them and use lungs that we or others would not have used. And after we've done several hundred of those, we showed that the long-term outcome was equivalently good or better than standard lungs that people were using in North America. So what did this do for our program? In the early days, we kind of pushed lung transplantation with using extended donor lungs and lungs that were on the edge, but we thought we could pull through. And in the mid-2000s, we kind of plateaued at about 100 lung transplants a year. In the EVLP era, we totally doubled the number of lung transplants in our program, even though the number of organ donors did not significantly change. Here you see the lungs in blue that go straight to transplant, in yellow the ones that go through EVLP before transplant. And last year we did 217 lung transplants in 1 year. That is the largest program in the world. But more importantly is we have not only provided lung transplant to more and more people, but we're providing it with a better result, with improved operative mortality. You can see in the early 80s and 90s, we quoted an operative mortality of 50%, and that was real. Now we do over 200 lung transplants with an operative mortality of 2%. So it's come a long way in terms of life-saving therapy. The average ischemic time in the United States is 5.8 hours for lungs. Surgeons tend to be very conservative, and so John Young decided to publish these results looking at cold preservation of lungs, where we've gone over 12 hours versus less than 12 hours, and showed that you can safely, and there's no significant difference in lungs preserved over 12 hours ischemic time. And you can see by the two red stars, those were the only two mortalities. You can see that the mortalities were not at the extremes of ischemic time that was approaching 18 to 20 hours. So this activity has helped us to improve the logistics in the OR. This is one of the emergency boards at Toronto General Hospital. It's not an unusual event where we have so many organ transplants. You can see there's a laparotomy washout, a kidney pancreas, a liver transplant, double lung, kidneys, double lung, heart transplant, double lung, ex vivo lung, and so on. Now, I didn't do all those transplants. I was on call and could coordinate it. And by using EVLP, this is the way we can sort of stagger the transplants. The first one was EVLP, went to 2 single lung transplants. The second one went straight to a bilateral lung transplant. The third one was turned down on EVLP, and the fourth one was put on EVLP to wait until we had a surgeon in an operating room ready to do the transplant. It's also important to know that transplantation continues to grow, and it is not that attractive as a career to all caregivers in healthcare. There's a lot of night work, and it's hard to do. And I think the future surgeons are not looking at transplant as a career. And in fact, when you look at this data published from the UNOS, data from WashU group analysis, shows that transplants done at night in green do significantly worse than transplants done in the daytime. Human beings do their best work in daytime hours, according to our circadian rhythm that we have. So we looked at the concept of could we really push the boundaries of organ preservation, and we showed that 10 degrees was better, but more importantly, Adil Ali and Marcelo showed that static lung storage at 10 degrees is far better than 4 degrees, it's far better than 15 degrees, and that's because it maintains mitochondrial function, energy production, and oxidative function of mitochondria in the lung. And so we designed a study to avoid overnight lung transplants. If a lung was cross-clamped at 6 p.m., we would put it at 10 degrees and start the transplant at 6 a.m. And so on, a maximum of 12 hours, so that we don't do transplants at night. In the first pilot study, you can see these are the actual x-rays of the patients. You can see the donor, the recipient on admission, 24, 48, and 72 hours in the ICU. And you can see that there was no primary graft dysfunction at 72 hours. The hospital length of stay was very average for us, 17 days, with 100% 30-day survival. So we did a trial including 3 centers, Toronto, Vienna, and Madrid. And again, in the bottom in red, you can see the first lung preservation times ranged from 7 hours to 17 hours. And the second lung preservation times range from 8 hours and 51 minutes to 19 hours and 41 minutes. So significantly longer preservation times. And again, on this table, if you look at the items in red, you can see the incidence of PGD3 at 72 hours was 9.3% in the standard arm, and in the 10-degree arm, 5.7%, with 100% 30-day survival again. And looking at the long-term outcomes, airway complications and survival were equivalent in both 10-degree and matched controls. So the question is, how far can you push this? We've changed the paradigm. You've got a cold ischemic time 1, then you've got normothermic EVLP, cold ischemic time 2, and then a lung transplant. And so, some of our research work has shown that the normothermic ex vivo lung perfusion really interrupts the ischemic time and recharges the lungs for the next phase. And this is a fascinating thing that I never thought we'd see in our lifetime. Adil took lungs out of pigs and stored them for 3 days using this strategy. 3 days, the organs were out of the donor, so the cold ischemic period followed by EVLP alternating for 3 days, and then a lung transplant. And on the right-hand side is the graph that shows the function of the transplanted lung with the contralateral lung clamped. So PO2s of 400 after being out of the donor for 3 days. And we're using that strategy to say, can we now look at repairing lungs in a more meaningful way to repair injury and prepare them for transplant. We're looking at perfusion, drugs, energy devices, biologic devices. I, of course, have been very interested in cell and gene therapy, and I'm going to talk about it. I just want to talk a little bit about precision diagnostics, because when we talk about precision diagnostics in medicine today, you can go to the oncologist, get your biopsy, and know by tomorrow what the gene profile of your tumor is, what's the best chemosurgery, radiation protocol, and so on. These diagnostics have not been driven and developed by industry to serve transplantation. Finding out by tomorrow is okay for your tumor, it's not okay for your organ that's dying or at risk of having significant injury. So we've been looking for years at biomarkers that predict whether the lung is going to have a good outcome or not, and we saw some inflammatory cytokines, IL-6, IL-8, IL-1 beta, are very predictive of function after transplant, and we've been working to develop a rapid diagnostic called TOR-DX to give you the Toronto lung score. Is that a good lung or not? Is it a risk to use or not? Does it have significant inflammation or not? So you can see now that using EVLP, you can interrogate the lung better, you can treat it, but you have a significant amount of data coming in from the donor, physiologic, biological, biomarkers, and imaging data all pouring out of that lung. And in fact, now it's a huge amount of data. And we found our success rate was significantly higher than others. Why? Because there are things we're looking at that we know from experience that maybe some centers don't have. By the same token, there's so much information that no human being can really look at and assimilate all of the information and use it to their best advantage. So we developed the Insight TX model for EVLP decision support, taking all of the data from EVLP, using machine learning and AI algorithms to give you a score, Insight TX, that tells you that you transplant that lung, green, go. The chance that your patient will be extubated in less than 72 hours is very high. Yellow, caution, there are some issues with it, but still compatible with survival and saving a patient's life. Or red, the lung is not suitable for transplant. So we published this recently, and really it's the first machine learning algorithm for ex vivo organs to accurately assess organ health and suitability for transplantation. And we put in over 91 parameters that are evaluated and scored to come with a guidance to the physician or surgeon doing the EVLP, if you will, so that they can do that. But we'd like to take this a little further. Like, can you actually predict the concept of digital twins in aerospace and automobile engineering is very advanced. You don't have to crash a plane to know it's going to crash. You know, you can predict the outcome in silico. And by the same token, we're developing digital twins of lungs so that we can actually take the simulated information, and as you get more and more information, your prediction gets more accurate to have a digital lung, so you'll know what this lung's going to be like in 4 hours. You know what it's going to be like in 72 hours after transplant. So on ex vivo lung perfusion, you know, the easiest lungs to fix are low PO2. You put it on EVLP, clear the edema, the oxygenation gets better, and you transplant the lung successfully. We had a donor with high pulmonary artery pressures. We weren't sure if it was chronic or acute. There were some clots in the PA, as you see there. So we made the diagnosis of pulmonary embolism, maybe acute on chronic, we weren't sure. We treated the lung on EVLP with alteplase, just like you would treat a patient. We watched the response. The PA pressures came down as the clot was lysed. We did a biopsy, as you can see in the bottom left there. No signs of chronic pulmonary hypertension, so we successfully transplanted those lungs. Those are lungs we treated, like we treat a patient in a personalized way, and we would not have transplanted them had we not had the assurance and the opportunity to treat. We're looking at how to treat lungs with a pneumonia. Many donors have ventilator-associated pneumonia, and when will these lungs be sterile and able to be transplanted safely? We also looked at treating hepatitis C positive donors and decreasing the hepatitis C in those lungs, and we now have developed a UVC light to sterilize organs so that can we actually create organs that kill all the pathogens and don't transplant any. This study we published in Lancet was a multi-organ study. There were 9 lungs transplanted. 2 out of the 9 had hepatitis C eradicated from the organ so that we did not have to treat the recipient with antiviral. So not a home run yet, but I think it's possible that we will be able to remove pathogens from organs. Marcelo's doing a very exciting project where he's looking at taking A and B organs and making them universal organs. So using ABOzyme to remove the A and B antigens, and he's shown that you can successfully do it, and now we're using CRISPR gene editing to make sure that those AB enzymes don't come back. So, you know, we talked about the IL-10, and John Young showed that he could achieve the same IL-10 upregulation in the blue squares on the right-hand side that we did in the donors, Stefan Fischer's work and Salo Martin's, and then Tiago Machuca, who's now running the program in Miami, did the survival experiments in pigs to look at toxicity and efficacy, showing that we had less rejection and better function of lungs in pig survival experiments, setting us up for the clinical trial. Marcelo Cipel then went on to do the human lung studies where he showed that he could take injured human lungs that we weren't going to use and bring them to transplantable quality, improving oxygenation, improving pulmonary vascular resistance, and more importantly, turning around that inflammatory cytokine profile that you see in the multi-organ donor with the high IL-1 beta, TNF-alpha, IL-8, IL-12, and IL-6 all reduced, IL-10 obviously increased by the gene therapy. Shin Hirayama did a very nice study. This rainbow picture here is the gene expression in the rat lungs treated at the time of transplant, showing that you had IL-10 production in the graft for a year after one treatment at the time of transplant. And so you've created your own immunomodulating lung, if you will. Kumi Misaki has just finished her PhD thesis with me, and her idea, like when we learned about CRISPR and thought, well, you know, if you could gene edit organs with CRISPR, then you've got more precise editing, less off-target, permanent gene changes. So what she was looking at, can we do a one-and-done process? And we realized that CRISPR takes about 18 to 24 hours to work. So she designed a dual vector where you have the add IL-10 that peaks and decreases by about 24 to 36 hours. So you've got it for the time of reperfusion injury, and at that time your CRISPR is kicking in, so you've got permanent gene editing for the rest of the life of that organ. So that's a very, very exciting achievement in the field. So we've been working on gene therapy. We're also working on, can you deliver cells to improve the lungs? MSCs on their own didn't work as well, and there's a number of reasons for that. But we then engineered the mesenchymal stromal cells to upregulate IL-10 in them, so you'll get IL-10 immediately at the time of infusion of these cells. And of course, when you put cells into devices, you've got to be sure, are they going to be stuck to the tubing? Are they going to be stuck in the membrane oxygenator and so on? So in the green dots here show that the cells did go into the lungs within the first pass. We had over 90% of the lungs cells trapped in the lungs. Stephen Juvet is doing a very exciting study where he'll take your regulatory T cells and amplify them ex vivo and store them frozen. When we get the lung, we put your T regulatory cells into the lung and introduce the lung to you in the context of self, and then use Treg permissive immunosuppression. So very elegant immunoengineering, which I think will improve the outcome of lung transplantation. We have the full pathway in the lab from cells to small animal to large animal, EVLPs and transplants, and then human transplants. We recently got a large grant from the New Frontiers, CIHR in Canada, where we are taking what we've learned in lungs and expanding that to help the other organs, so that those working on ex vivo heart and ex vivo liver, and here's the kidney as well. And you can see some of the systems are blood-based because the researchers feel that that's needed for that organ, and others feel that it's, acellular has been fine. And I think these are the things. I mean, the secret of our success really was finding out what is specific for the lung that is needed, and Trevor Reichman has made some very important advances in the ex vivo pancreas perfusion, both for transplant preservation but also for islet cell optimization. So we learned how to keep a lung outside the body without injuring it, and really that taught us a lot about lung physiology. Well, what about, can we just fix your lung inside you so that you don't have to take it out and repair it? So this is really applicable to gene repair, ARDS, and lung metastases. So we took this whole system that we developed for EVLP and modified it for IVLP. So as thoracic surgeons, we often, for various tumors like colon cancer, sarcoma, kidney cancer, we resect metastases in the lung. Those little white spots in the black lung are lung metastases. But 30% of patients will recur, and sometimes if you have more mets, you're more likely to recur than if you have less metastases. And the reason for that is, if you look on the right there, the blue color is we resect the large tumors that we can feel and see, but there are micrometastases that are cancer cells, and that is why 50 to 60% of the patients will recur when you resect metastases in the lung. Now, a lot of times this is limited because because of toxicity, you can't deliver that chemotherapy to the patient, and therefore what we did is develop IVLP so that we could in vivo perfuse the lung. You can see a cannula going into the pulmonary artery, 2 cannulas coming out of the pulmonary veins. So you give high-dose chemotherapy to the lung with no significant chemotherapy to the rest of the patients. You don't have eye toxicity, liver toxicity, or kidney toxicity. Now, this is not a new concept. You know, a long time ago, people were looking at this concept. It's a great idea, but they didn't have the technology to protect the lung. And you can see the left lung in this picture is completely whited out after their in vivo lung perfusion reported by Mike Burt and Bill Putnam. So using our EVLP technology, we developed a current version of IVLP that we're doing and have brought clinically. We've done about 15 patients, and then, you know, doing the dose phase 1 studies of dose escalation, both in sarcomas, and we have a current trial that we're running on colorectal metastases, again, dose escalation. This is a typical patient, metastases in both lungs. We resect them, and then we do IVLP of one lung. So here you can see day 1, you can see the left lung is a little bit infiltrated, clearing by day 2, clear by day 7. For those of you that want to look at the actual technique and details, we have a Toronto Video Atlas surgery that you can get online, and it's free, and you can actually see the details of the procedure. Marcelo made a very nice movie of this. So to close, I'd like to just talk about the concept of engineering superorgans and achieving this vision. I mean, it's clear we're making life a bit more complicated. I don't need to tell this audience, but on the other hand, we have unique opportunities for advanced organ management, advanced diagnostics, personalized therapy, devices to support organs, staff that will be needed to deliver the treatment, and system changes in organ allocation, transport, and distribution. I strongly believe that the future of transplantation will look like this. We will take organs, bring them to an organ repair center, fix them, optimize them for the specific patient, and then transport them out to the patient to be implanted. And this may sound like science fiction, but we established the first organ repair center at Toronto General Hospital in 2008, and that's what it looked like. We then, this is the original component system, and we now have 3 or ex vivo organ perfusion centers, rooms in Toronto General ORs that you see here. We built the first lung hospital in the world with United Therapeutics. Lungs are brought in. This is a 28,000 square foot 6 OR facility to repair lungs capable of doing 1,800 lungs a year. The people here are organ perfusion specialists that are all trained at Toronto General, and the data is sent to you on your iPhone in real time so that you can make the decision. We built Lung Bioengineering 2 in Jacksonville, Florida, in partnership with the Mayo Clinic, and are now building Lung Bioengineering 3 and 4 in Phoenix and Toronto. So really we're dotting the continent with lung repair centers to be able to provide this service across the board. Now, we can't keep building whole operating rooms for each organ, and therefore, really, we've reduced that whole operating room into one machine, and hopefully make it simple enough that one organ perfusion specialist can look after 10 lungs at a time rather than 1 lung at a time. In terms of transplantation, if the lungs are good, we go straight to transplant. If they're bad, we decline for transplant. If they're in between and you're not sure, then you evaluate them on EVLP and hopefully will be guided with diagnostics as we go. The current ecosystem is transplant donor hospital, transplant hospital. We transport organs usually by air or land between them. I think in the future, lungs will stop off at an organ repair center. And when you think about it, why would you use a whole Learjet to transport something that weighs 2 kilograms? And each flight costs us $30,000 to $40,000. So we've been exploring the ability to deliver lungs by drone. We've been, this is a drone flying across the Toronto skyline carrying a lung for a transplant. It's very difficult to fly in populated areas because of radio frequency interference with your GPS. We built a ballistic parachute so that if the engine fails, it'll bring the organ down safely and so on. And now we're flying in and out of Pearson Airport so that we can fly in and out of commercial airspace as well. safely. We've created a drone corridor between Pearson Airport and Toronto General Hospital, again, to build the concept of transporting organs by air. Again, it was highlighted in the Toronto Life magazine as the 9th best reason to love Toronto, because organs are delivered by air. So, I thank you very much for the privilege of this presentation. I'd like to acknowledge the Latner Thoracic Research Laboratories. We're 140 people working in that lab, and I get to stand up here and present their phenomenal work. And of course, the Toronto Lung Transplant Team. This was shown at our retreat last year, but we get together every year to look at our results, look at the future, and say, what are we going to do next? So thank you very much for the privilege of this presentation.